start with complex disease states and how they can be caused or propagated by tick-borne disease. So at the bottom you'll see some disease states here. Very common is a mood disorder. So you see mood disorders here, anxiety, depression, that type of thing. You'll see a lot of autoimmune diseases and even cancers, heart disease, digestive issues. These are the conditions that people are walking into the office from, and how did they get there, and then how do we work backwards? So let's reverse this picture and go back to the top. So we see the conditions here that the patients are suffering from, and these are what they walk in with. How did this start? So we'll start up here at the antigen presenting cell. The antigen presenting cell is when the body is being presented with some kind of pathogen. In this case, we're talking about tick-borne disease. It presents to a naive T cell. That naive T cell isn't sure what it's supposed to do when it grows up. Now, the tick-borne disease wants to survive. So what it'll do is it'll create a microenvironment around itself and in the body to drive towards this side of the immune system, which we call Th2. And so the actual bug creates a microenvironment around itself to propagate a Th2 response. Why would it do that? Because if it goes over here to the Th1 response, this is where the immune system is very effective at fighting infections. So we have our natural killer cells and our Th1 differentiated cells. This is what helps fight the infection. So the bug actually is trying to evade the immune system, and the way it evades the immune system is it creates a microenvironment which will create sometimes a systemic environment of Th2 dominance. What does that mean? Well, Th2 dominance and Th17 dominance, just follow the yellow brick road. The arrows, this is what leads to the autoimmune disease, cancers, and these chronic diseases, which is what they're coming in with. So in this case, the immune system can't fight the infection because it's stuck in this side of the immune system. We want to try to reverse this and get it back over here. So in tick-borne disease, it's very effective. These bugs are very effective at evading the immune system. We've heard this language for some time. What does that actually mean? To evade the immune system, it's going to be dominant to this side of the immune system and not this side of the immune system. So tick-borne disease leading to autoimmune disease, it's a little bit nuanced. We'll get into that because we know that Th17-driven immune differentiation will lead to autoimmune disease. This is the pathway of autoimmune disease. But let's digress a little bit. So what will happen is you'll get a bug, and the immune system tries to digest that bug. Now the bug is trying to evade the immune system, but even when the immune system does see it and it can't clear the pathogen, it's held up in this garbage bag of the cell, right? And that cell isn't cleared, so then the cell breaks down. Now in this microenvironment, we have pathogen, PAMPs, and we have self-tissue, DAMPs. And now we have both of these debris fields in the same microenvironment. So the immune system says, hey, I got to clean this up. I got to fight the bug, but I just have to clear out self-tissue. When they're all in the same microenvironment, there's confusion at times in the immune system. It's very common for the immune system to cross wire, and instead of attacking just the pathogen, it starts to attack the self-tissue. The immune system now recognizes the self-tissue as pathogen and starts to attack it. And that's the definition of autoimmunity, when your own immune system attacks self-tissue. So we see on this picture, this is the immune system. You notice over here we have your gut barrier, and here we have your gut-associated lymphoid tissue. If we follow the picture down, when you're in a chronically inflamed state, that chronic inflammation will lead to tissue breakdown. Up to 85% of this immune system lives right around the gut barrier. So when we get tissue inflammation and tissue breakdown, it's extremely common to get breakdown of the gut barrier. This is what leads to leaky gut. At this point, we have food peptides coming in that are supposed to be broken down into their amino acids or small peptides. They're bigger peptides coming into the system, and now these are recognized as foreign because they're not supposed to be that large of a peptide coming in. When this peptide comes in, the immune system now is presenting this as foreign material. So if we don't fix the gut, we're going to be constantly driving this pathway. So while we fix or remediate this whole system, we have to spend some time on the gut barrier, because if we don't, we're going to reactivate this entire system. Our goal is to drive Th2 back to a Th1 state. The Th1 and the Th2, you'll see here, they block each other. So they're kind of like the Hatfields of McCoys. If you have too much Th2, that inhibits Th1. If we inhibit Th1, we'll inhibit natural killer cells and we're not able to fight the infection. So we have lack of resolution. So our goal is to drive it over to Th1, and eventually we want the regulatory cell to actually mitigate how much Th1 and Th2 response. So our first goal is to drive away from Th2 and Th17 towards Th1. In order to do this, it has to be a multifaceted approach, because we have to heal the gut wall so we're not constantly driving this allergy response or food antigen response. So we have to heal the gut. We need to dampen the inflammatory state, and then we try to use specific herbs or medications to enhance a Th1 response. Whether that's your antibiotics, which will help over here, herbs, perilla or berberine, or any of the herbs that we are familiar with, cryptolepis, we want to drive it back over here. This is very helpful. When we're Th1 insufficient, we also have mitochondrial insufficiency. So this is very common for patients to be tired, have brain fog. Their cells can't make the energy. When we're Th1 sufficient, we're going to have normal autophagy, we're going to clear our debris fields, and we're going to have normal mitochondrial DNA replication. When we're stuck in a Th2 dominant state, we're going to have mitochondrial breakdown, we're going to get mast cell activation, histamine response, increased swelling, we're going to get that allergy asthma type response, we're going to get that inflammatory response, which eventually will lead to this autoimmune disease or autoimmune-like state, chronic inflammatory state. Many times this is called mast cell activation. What does that mean? That means we're inflamed, releasing histamine. That by definition is a Th2 dominant state. So we want to work backwards to get towards a Th1. So many times our patients will let us know that they have a lot of food sensitivities when they have tick-borne disease, which if we follow the picture, of course, we have the breakdown of the gut wall, so we have the food peptide coming in, and simply avoiding the food, while it may be part of the program, can't be the only piece, because we have to heal the gut wall and we have to resolve the tick-borne disease. So these food peptides come in, and then we get molecular mimicry, which means the food looks a lot like the bug, so whenever they eat the food, they're going to have the similar reaction that they had when the pathogen was active in the body. So they mimic each other. They drive this evasive type of immune surveillance system, so they're evading the immune system. So all of our patients with tick-borne disease will have increased probability of food sensitivities by the very nature of human physiology. This is evidence clinically. I had a patient, it's the craziest thing I've ever seen. Patient had a tick embedded, had the bullseye rash on her left deltoid here, bullseye rash, Lyme disease, fully diagnosed, kind of resolved, but every time this patient ate gluten, the bullseye rash came back. So clearly we didn't need more antibiotics for gluten. What we needed to do was shift the body over to a Th1, right? We needed to avoid the constant simulation of infection, which was the food pathogen, and heal the gut barrier. So very common in tick-borne disease is this mood disorder down here. So we see a lot of depression, anxiety, schizophrenia. In fact, it's been documented that 65% of schizophrenics actually have Bartonella. This is not where psychiatric medication is going to win, because it's really driven by a pathogen. It's pathogenic driven, and the psychiatric meds, while they may help them feel better for a period of time, it's not resolving. So common to have this mood disorder with tick-borne disease. Why is that? Well, we have these inflammatory cytokines. So we have the inflammatory cytokine model of anxiety, the inflammatory cytokine model of depression, the inflammatory cytokine model of schizophrenia. Where do we get that inflammation from? That's from the tick-borne disease. The tick-borne disease comes in, drives the inflammatory state, brain on fire, leads to those mood disorders. They wind up in psychiatry, and that's not going to be the only answer. They're going to have to resolve their tick-borne disease to resolve this mood disorder to get to the root cause. So we see a lot of these chronic conditions down here. So when would we consider tick-borne disease? Well, first of all, I think if they have a chronic unresolved issue, you have to ask yourself, what would be driving this? And we know tick-borne disease is very evasive to the immune system and leads to an inflammatory state. So if you're seeing patients that have chronic unresolved issues, or maybe the therapies that you've tried have not been effective, you have to think maybe there's a pathogen here, a stealth pathogen, which is tick-borne. So it's not necessarily just a hiker or somebody who has been bit by a tick. You want to consider these tick-borne diseases in all of your chronically unresolved cases. If it's there, great. If it's not, great, but you want to put it on your DIFF-DI. So very important with this picture as well is when patients are chronically ill and they've suffered for a long period of time with the things on the bottom, they start to have, even if it's not a mood disorder that they present with, they're going to start to develop that. They're going to lose sense of self. Their community is going to go down. They're going to have reproach behavior. They're not going to want to go out and socialize. And the very fact of love and appreciation and socialization helps to drive a naive T cell to a T regulatory cell. So when we lose this, we lose our governor to even regulate the entire immune system. So this is like a snowball that gets bigger and bigger and bigger because these people that are suffering from chronic tick-borne disease, they start to not even have normal social habits. They're not socializing. They have lack of enjoyment in life because they feel bad all the time. That has a multiplier effect because they're not even able to drive this regulatory system. So while this may seem a bit overwhelming, I tell patients you have to drink out of the fire hose before you can drink out of the water fountain. So it's a lot. You can't fix part of this picture. You have to fix the gut wall. You have to remove the food antigens that are irritating them. You have to work on killing the pathogen. You want to have your normal regulatory modulators like your vitamin Ds and your glutathiones in addition to your killing agents, whatever you decide to use. So this picture has to hit all sides. You can't fix one little piece or one little piece. This seems like maybe you're over treating, but if you're not treating the whole picture, this is why it keeps revolving, 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 and not resolving. You want to not have revolution, you want to have resolution. So don't be afraid to take a full, holistic approach where you're fixing gut, eliminating foods, healing the gut barrier up, shifting from Th2 to Th1, regulating the immune system, giving your patients love and appreciation and understanding, listening to them. All of this needs to be done in conjunction at the same time. You can't fix one leg of the chair at a time. All four legs need to be fixed at the same time or the chair will fall over. So even in patients' discussion, when I talk to them, I said, well, which part do you want to fix? If you don't fix this and you just work on the gut, you're going to get tissue breakdown and it's going to lead to leaky gut again. If you just try to fix this, you're going to have constant food antigens presenting to the immune system and you're going to drive this whole system again. So it really has to be a whole system, multi-system approach to resolve tick-borne disease. So in considering a case study or two, I had a patient once who was on 23 years of antibiotic therapy, and yes, they still had a pathogen, but the body couldn't resolve the pathogen. So remember, when you're giving large doses for long periods of time, antibiotics, you're also destroying the mitochondria. So the body doesn't have enough energy to resolve, and it becomes reliant on the antibiotic. When you take the antibiotic away, the body has no ability to reboot. So 23 years of antibiotic therapy, and the other provider recommended another year. It's not going to resolve with 24 years of antibiotics if it doesn't resolve with 23. So you have to take your clinical acumen, support the mitochondria, and allow the body to recover to support Th1. So recently I had a patient come in, 54-year-old with rapid onset Parkinson's. So she comes in, she's tremoring, Parkinson's, been to the big hospitals. Her husband is an MD, PhD immunologist. So it was a little intimidating. So she comes in, rapid onset Parkinson's, post-COVID. And when we did a little bit more investigation, it was actually Bartonella, and the Bartonella was reactivated by the COVID infection and started her on her road of Parkinson's. Now, why was that? That was because she was already Th1 insufficient, leading to another infection, triggering the original infection to come back. It was hiding out, latent. So what we did with her is we certainly took care of the BART as best we could, but our protocol over 9 months was to reestablish healthy mitochondria, shift away from Th2 to Th1, and 9 months later, she's 95% resolved from a clinical diagnosis of Parkinson's disease because of the strategies, not just killing the bug, but also reestablishing the normal immune system. So in testing, what some of the challenges are is if your immune system isn't functioning correctly, it may not even be able to make the antibodies. You may have the immune suppression, so you don't even make the antibodies. So this is why direct detection may be more relevant to some of your patients other than just antibody testing, so you can actually see the bug. So for your chronic patients, whether you've tried to regulate their hormones, or you've tried to fix their leaky gut, or you've tried to work on their mast cell activation, or their chronic, what I call I don't feel gooditis, and it's just not working and it doesn't make sense. Why isn't this working? This should be helping this patient heal. I keep hitting roadblocks. Every time they get stressed, everything comes back, but their numbers look good, their labs look good. You really want to put on your differential diagnosis tick-borne disease, because that could be the underlying cause of their hormone dysregulation, their mood disorder, their chronic digestive issues. All of that can be secondary to tick-borne disease.